Great. Well, our panelists are assembling, and we're going to make a few very brief introductory remarks, introduce the panelists, and then get started. My name is Ron Valdesari, and I'm the Deputy Assistant Secretary for Health in the Department of Health and Human Services, and as such, my office is particularly involved in national strategies to improve health outcomes for HIV/AIDS as well as viral hepatitis. And as if this issue of substance use and preventing overdose wasn't complicated enough, unfortunately we have to make it even a little more complex and remind everyone that in addition to the medical consequences of addiction itself, and in addition to the risk of overdose, there are long-term sequelae related to substance use. Most of us are very familiar with the intersection of HIV and injection drug use. We're less familiar as a nation with the terrible burden of viral hepatitis that's related to substance abuse. In fact, several of us in the audience, myself included, just came back from a meeting that was held at the Centers for Disease Control and Prevention in Atlanta, Georgia, focusing specifically on the hepatitis C epidemic in the United States. And I do want to point out that our friends at the National Alliance of State and Territorial AIDS Directors left a handout out front you should definitely pick up. But I want everyone in the audience to know that the CDC is reporting for the past 2 years in a row substantial increases in acute hepatitis C infections in the United States among young injection drug users who began by abusing prescription opioids. So we have this long-term sequelae to deal with as well. And our panelists today then are going to talk not only about their efforts to treat substance use and prevent overdose, but also will touch upon efforts that help protect people from infectious diseases like HIV and viral hepatitis. All of our panelists are quite distinguished, and they have long bios that you can read in your packet. So I'm just going to do highlights. Our first speaker is Dr. Hillary Kunins, who is the Acting Executive Deputy Commissioner for the Division of Mental Hygiene, as well as the Assistant Commissioner for the Bureau of Alcohol and Drug Use, and this is at the New York City Department of Health and Mental Hygiene. Hillary, in that position, among other responsibilities, oversees the intranasal naloxone distribution program, and she has a very long and substantial history in substance use treatment. Our second panelist is Mr. Donald Davis, and Donald was formerly the viral hepatitis integration project coordinator at the New York Harm Reduction Educators Group in the South Bronx. He thought he was going to retire to Louisville, Kentucky, and once he got there, became engaged with community leaders and is working with various community leaders there in the Louisville area to raise awareness about heroin and prescription drug abuse. Our third panelist is Dr. Tracy Green, who is an assistant professor of emergency medicine and epidemiology from Brown University, has done extensive research in drug abuse and addiction, and is particularly interested in the intersection of substance use and HIV, with a strong focus on populations who are incarcerated, and so we bring in the very important correctional health perspective. And last but certainly not least, Dr. Josh Sharp Stein, who is currently the Secretary for the Maryland Department of Health and Mental Hygiene. Prior to this position, Josh served as the Principal Deputy Commissioner at the FDA, and before that, for approximately 4 years, was the Commissioner of Health in the city of Baltimore. So Josh certainly has a lot of firsthand experience in the real world of public health. So we've got a great panel for you today, and I'm sure they'll all stay on time so they can take questions from you when they're finished. Thank you. Hillary?
Good morning. It's really a great pleasure to be here, and thank you to Director Botticelli and the ONDCP for having me and to speak about our work in New York City. It's also incredible to be here with so many of you who I know from email and phone calls. We really have formed a real community around working to end this epidemic that I have found really inspiring as I have transitioned from my clinic with one patient, one exam table, one at a time, to the world of both public health and increasingly the worlds of intersecting with my colleagues in public safety. I want to just start by telling the story of RxStat in New York City, which really came together in our last mayoral administration under the Mayor's Task Force on Prescription Painkiller Abuse. RxStat became the data work group for this task force, convened, spurred on by our colleagues at HIDA, New York and New Jersey, by the Department of Health and Mental Hygiene in the city. This group has continued to live on as the data arm, bringing together a diverse group of colleagues, district attorneys, prosecutors, human resource administration, us in public health, to really begin to have meaningful conversations around how to address the problem. We overall take a public health approach to track drug use and associated health and social consequences. It is formed around the data, and our hope is to grow it into initiatives that different sectors in New York can take responsibility for. And I'm really struck by the other scales that we've heard about this morning. And as you all know, New York is big, very big. 5 counties, more than 8 million people. So it is possible for me to sit on a panel next to someone who I probably worked with down the street for more than a decade, and I'm just meeting now. So that is our challenge in New York, is really how to keep communication going, how to not step on each other's toes, how to extend each other's work, and really make sure we're working in concert. So RxStat has set a primary goal of reducing overdose deaths and other health and social consequences of drug use. And to channel the words of Chauncey Parker, who couldn't be here today, the head of the New York, New Jersey HIDA, this is our North Star. This is what organizes us. This is a common goal that everyone at the table can agree with. I want to share with you the next couple of slides some of the New York City data from Department of Health and Mental Hygiene to give you a sense of how this began to form our work together. On this slide, you can see a graph of unintentional opioid analgesic overdose deaths that have increased 4-fold since 2000. The blue bars show the number of deaths in New York City. The orange graph shows rates. The main point here is that there has been a steady increase since 2000 in the number of those deaths, just like what's happening in the rest of the country. We look at our data by borough. And what you can see that's so very remarkable on this slide is what's happening in one of our boroughs, Staten Island, reflected by the light blue bar, the light blue line up top. The increases in opioid analgesic overdose death rates are highest in Staten Island, in excess of 4 times the rate of every other borough. This graph is what animated our coming together around RxStat and motivating our work to really take action. We also work with our state partners to gain access to prescription drug monitoring program data. And we look at it at the health department, I think in a slightly different way than gets commonly discussed in public safety circles. We look at prescribing rates per capita, you've heard about some of this morning, and have developed some indicators around dose, duration, and days supply that we track. What this graph shows, and this is a little bit older data, is that neighborhoods with the highest rates of opioid analgesic prescriptions also have high rates of unintentional overdoses. The map on the left shows rates of prescribing. That dark blue island is Staten Island. Echoed on the right side, opioid analgesic mortality rates. Same dark blue, have the highest rates. That's Staten Island. Finally, I want to show you what's happening in our city with heroin. And here I think we depart from other counties, many parts of the country, which is that unfortunately we have lived with heroin and lots of it for many years. We saw decreases in the late 2000s, and then it went up in 2010 and 2012. So like other jurisdictions, we are encountering new heroin use, and increasingly, and not shown here, through our qualitative surveillance, new users, particularly in Staten Island, far out in Brooklyn, and other jurisdictions. So through this, we have developed a number of initiatives, some public health-led, some public safety-led, and I just want to quickly take you through a couple of those. We've issued opioid prescribing guidelines targeted to both primary care and emergency department physicians. We conducted with our CDC colleagues, with help, Chris Jones is here, who we worked with closely to develop a detailer campaign to Staten Island, and we're evaluating the results now. And finally, the extent to which naloxone distribution has taken off both nationally and locally has been phenomenal. We've been in this intranasal naloxone distribution since 2009, distributing to our syringe access programs and other community partners. We increasingly have moved into drug treatment programs. An early adopter of first responders were our peace officers or security staff in our Department of Homeless Shelters, who were amazing adopters. And most recently, which has gotten tremendous news and which we're so excited about, is a pilot program in Staten Island you heard about already from the director, where Staten Island police have reversed more than 6 overdoses. Yet the work is not done by any means, and I think this panel reflects our longer range concerns about seeing increases in hepatitis C, and surely there'll be a next virus after that. So the work is really about prevention and preventing disease transmission and saving lives. We need to reach new users, and in New York City, we are hoping to capitalize on our very strong system of harm reduction providers who provide syringe access and other important linking and counseling services, as well as the other efforts here. And in my 0 minutes of time, I'll just mention a new mayoral initiative, a task force uniting behavioral health and criminal justice, because as a way to prevent engagement in the justice system and prevent further recidivism and addiction. So thanks very much.
Thank you. Thank you, Hillary. We'll take questions at the end, as the former panel did. Donald?
Oh, I don't need this. I didn't bring any slides. I just want you to pay attention to what I have to say. I believe in harm reduction. I'm a harm reductionist from the heart. I believe that syringe exchange access is a cornerstone to hepatitis C prevention, that syringe access is a bridge to treatment, that your syringe access programs are the proven model for the integration of overdose education and naloxone distribution. I started out in this field back in 1996 in Ann Arbor, Michigan, at a HIV and AIDS resource center, and I started really pinpointing hepatitis C because I've had hepatitis C. I'm not one of those people that'll hide anything about myself. I'm a recovering drug addict. I've been clean for 22 years. I've had hepatitis C. And I took it upon myself at that agency to start a support group for people with hepatitis C. And we got people into the support group, got several people treated. I've been undetectable for my hepatitis C for 15 years. So I know that the treatment works. I took the old three injections a week of interferon and the ribavirin and suffered through that and got sent home from work for the mood swings and everything, but that was okay. Once I finished what I had to do in Ann Arbor, I moved to New York. And I was hired as the hepatitis coordinator for a CDC-funded project, the Hepatitis Integration Project. And when I hired in, I thought that it was going to be continuous, that after we did that first 5 years that they would refund it, and they didn't. So we had to run around and try to find money for that to continue doing hepatitis C testing. We got people into treatment. Several of our using addicts were sent over to Dr. Brian Edlin and the late Michael Carden's program, who were treating people who were actively using, and it worked. And in that, being in the South Bronx and East Harlem, which have some of the highest rates of hepatitis C in the city of New York, it was amazing to find how many people had not been tested for hepatitis C and who didn't know that they had hepatitis C when I tested them. I did all the testing and everything, and we have a mobile unit. I did testing at our mobile unit, and we would bring people back in. And what I say about syringe access and naloxone distribution is this is when you're able to engage active users. Because a lot of active users aren't engaged if they're just getting syringes from wherever they get them from. When you engage them, you can bring them into your agency. You can sit them down for case management. You can sit them down for health care if they need health care. You can go with them to a fair hearing to get their health care, their Medicaid turned back on. So harm reduction, you know, a lot of people think that harm reduction is about just giving out clean syringes. Harm reduction has a lot of aspects to it. Education, prevention, naloxone distribution. I've had to reverse an overdose in one of our offices. We had an office in the South Bronx and an office on 121st Street and Lexington Avenue in East Harlem. And we had a guy that was in our restroom shooting up, passed out. He was in there too long, and everybody else panicked. I was a phlebotomist, so we had the naloxone with the needle, and I said, well, I don't mind sticking him, you know, and I stuck him in, you know, and I'm going to talk about Kentucky in a minute because I'm there now, but stuck him, rolled him over on his side. He threw up a little bit, but he was okay. He cussed me out, but then later on he came back and thanked me, all right? And so, you know, I don't see where distributing naloxone to anyone hurts. Now, I'm going to get to Kentucky. I retired last year, and number one, I retired because of my age, and then I retired because they just didn't have any more money to pay me to do my hepatitis C work. So I said, well, I'll go down to Kentucky. I have 3 sisters there, and I'll go down there and just kind of relax. I was there for 2 weeks. 2 weeks I was there, and I went to the store to get a newspaper, and on the front page of the newspaper, surge of heroin use in Kentucky. My retirement was over. And I'm not trying to say that I'm a superhero or anything like that, but it's that I care because I've seen people overdose. I've seen people die, and there's no reason for them to die. And when I look at hepatitis C, I know what group of people are at highest rates for hepatitis C, and it's injecting drug users. Okay, so lately I went to I met with the state hepatitis coordinator in Frankfurt, and she and I talked, and then I started just doing things and talking to people. And now I'm working with several other people, a gentleman who has a outpatient treatment center and some other community members, and we are working at trying to get naloxone distribution in Louisville. It's going to be a hard road, but I feel that we can do it. And you don't speak about harm reduction in the South, but we're terming it public health issues, which it is. So what we want to do is to get naloxone distribution. And I want to say this because being in Kentucky and just knowing people, I didn't have any idea that the heroin use was as high as it is in Kentucky. But I went to my veterinarian, took my cat into my veterinarian, get his physical and everything, and I was talking to the vet, why'd you move to Kentucky? What'd you do in New York? And I told him, and he said, both my parents died from hepatitis C. They were drug addicts, both of his parents. I worked with a woman at my job, part-time, and I was telling her I came here to DC last year in September to the hepatitis think tank, and I told her what I was going for, and she said, well, I have an uncle. He's a baby boomer. He used to inject drugs back in the day. He went to his doctor just recently. His doctor told him, how long have you had hep C? He didn't know he had it. And she also had a nephew who passed away from a drug overdose. So And one of the people that I'm working with, she has a son who has passed away from overdose, and she has a daughter who still uses. And she's had to give her daughter CPR until first responders got there. She carries a Narcan kit with her today. Everywhere she goes, she's got her naloxone kit with her. So I'm going to talk with the distinguished ladies from Kentucky before the day is over, and so we can try to start doing something in Louisville and wherever else in Kentucky since I'm there. And it's enjoyable. I do what I do because I love it. Thank you.
Thank you, Donald. Thank you so much, Donald. Now we'll hear from Dr. Tracy Green.
Thank you. It is a pleasure to be here today and to share with you some of the experiences and efforts in addressing overdose in the great ocean state of Rhode Island. While I do have my background in trainings in drug abuse epidemiology and specifically in HIV, I think a lot of the lessons we've learned, both from epidemiology, treatment, interventions, and certainly the community activism that brought together some of the most amazing scientific changes in this country's scene. It's really stepped up to the challenge, and I think we're currently faced with an even greater challenge in front of us potentially. Rhode Island, a state of just over 1 million people, 48 miles north to south, 37 miles east to west, has the highest rate of past month illicit drug use other than marijuana in the nation. Actually, Rhode Island tips the scale in the New England region across numerous indicators of drug-related harm. We also rank highly on national surveys on recent non-medical use of prescription opioids. Perhaps less unusual at this point is that Rhode Island is just like other states, with high levels of dispensed scheduled prescription medications, with 1/3 of her residents dispensed a controlled prescription drug in the past year. Also, like 20 other states in the nation, deaths from drug poisonings outrank motor vehicle crashes as the leading cause of injury death. But Rhode Island has been very much the canary in the coal mine, if you will, on the topic of drug overdose. 5 years before the national injury statistics broke, Rhode Island poisoning deaths exceeded those of car crashes, and more recently, as these data will hopefully convey. There we go. Another stark story is unfolding. This graph shows the counts of unintentional drug overdose deaths by quarter from 2009 to Q1 of this year. So just 2 months ago, these data have closed from our medical examiner. The purple portion of the graph depicts the total number of overdoses, and the other lines depict the drugs attributed to those overdoses according to our death certificates. There are 3 important take-home points in this that I'd like to highlight. First, there has been a substantial increase in overdose deaths, 119% increase to be precise, from 2009 to 2014. Second, the drugs causing these overdoses have changed dramatically and quickly. Prescription medication is no longer driving the high numbers of overdoses in our state. Illicit drugs are. When I came to Brown in 2009, prescription medication was contributing about 67% of the drug overdose deaths. And at that point, we already were at an epidemic level, and I was going around the state and advocating for more work on this particular topic and really attention to our prescription monitoring program, all the tools that we've been talking about throughout the morning here. However, in 2014, what we have is a clearly very different story. The 2 black lines indicate that an unprecedented 85% of Rhode Island overdose deaths now involve illicit drugs, and most of that is heroin. The third point is the upward trajectory in deaths has not been gradual, but rather punctuated by 2 very recent fatal overdose outbreaks involving illicitly synthesized opiates, namely fentanyl and fentanyl analogs. The initial acetylfentanyl outbreak occurred last spring, and another illicit synthetic fentanyl outbreak occurred at the end of 2013 and the start of 2014. So what is a state to do with such suffering and premature death? Well, first, we compared our numbers to what we already knew. Thanks to research funded and studies that were funded by the Centers for Disease Control and Prevention and the National Institute on Drug Abuse, we had a very good handle on the epidemiology of overdose in our state and region. But the more recent trends upended much of that knowledge gained, pointing to absolutely no geographic pattern, different from earlier investigations that I had done in the region, showing a non-urban predilection in prescription opioid overdoses and an urban tendency for illicit drug deaths. The deaths instead were spread throughout the state among both men and women across a broad age span. But the modal substances involved were consistently opioids. We deduced that we needed an opioid-specific statewide overdose prevention intervention. And this effort should be part of and complement our other efforts that were broadly working towards safer opioid state efforts, like the prescription monitoring program and pain practice guidelines. You know, luckily, as a species, we have two critical tools to address and help us through this work and this new puzzle. First, the basic human instinct to help others who are in imminent risk of death. And the second, naloxone. Other than large-scale access to medication-assisted therapies, distribution of naloxone is the only evidence-based intervention available in this country and shown to reduce overdose mortality at the community level. Until treatment access and availability can meet the need, avoiding death by overdose is key. Now, since 2005, we've had community-based access to naloxone through the PONY program in Providence. And community-based programs like PONY are absolutely critical. They are the foundation of our harm reduction efforts. And they're, unfortunately, though, with the training and know-how and the linkages to other services are geographically limited and few in our state. We also had tallied less than 10 naloxone prescriptions were written by prescribers and fills last year. So we strategized. We leveraged our injury prevention core resources, collaborated with, amongst our brought our informed leadership, many of whom had personally been affected by the overdose epidemic, and harnessed the tireless dedication of community harm reduction activists and recovery resources in the state. Rhode Island may be small, with limited resources, but we can fit all of our representatives for the stakeholder groups into one room, probably about half this size. And we can implement programs, however, on a statewide level that other states could only do on a pilot basis. And despite all the stark drug and overdose statistics that I just shared, Rhode Island boasts the highest H1N1 vaccination rates in the country, indicating that we have the ability to successfully mobilize public health resources when it's most needed. I share with you two unprecedented public health innovations that we used to address overdose. The first one brought our Board of Pharmacy, colleagues from the University of Rhode Island College of Pharmacy, and outstanding local leadership from Walgreens Pharmacy. We developed a collaborative practice agreement for naloxone. This mechanism allows pharmacists to undergo an online continuing education certification on opioid overdose and naloxone, and completion of which permits them to furnish naloxone to anyone without a prescription who walks in to a pharmacy. In fall 2012, we started a pilot program at 5 Walgreens stores, which was expanded statewide in the spring of 2013 after our acetylfentanyl outbreak. Currently, all 26 stores in Rhode Island have a CPA and stock naloxone. When I walked into our North Main Street Providence store last week, I purchased this for $40, got a AAA discount. It was really great. It's an intranasal delivery product. We have been able to double the community-based naloxone distribution in 2014 through this mechanism. The other innovation that I'd like to share is mobilizing our disaster management in the state. Overdose is a disaster in our communities. And we have, thanks to our efforts towards bioterrorism, created a public health infrastructure that we can mobilize. The disaster medical assistant team and the medical reserve corps in particular are a mechanism that could be used in every state to bring together and educate health professionals and law enforcement. In Rhode Island, we have the NOPE-RI, an overdose prevention education program for health and safety professionals. We've trained 5% of the Rhode Island MRC. That's 66 trainers. In 2014 alone, since January, we've trained 1,000 individuals, most of them in law enforcement and public safety. They also are a clearinghouse for all of our education in the state and can hand materials out very quickly. They are actually the ones who made the H1N1 vaccination possible throughout our schools. So our next steps, what does that look like in the state? First, we need to, of course, rigorously evaluate what we're doing. We have a mechanism where we're actually able to collect within a 48-hour period, reporting of suspected overdoses. We have EMS data to be able to look at real-time naloxone use in the field. We're documenting our efforts. We are trying to disseminate, and we believe that this is a mechanism for scaling up naloxone distribution, both efforts. In particular, we have 48 states that grant pharmacist collaborative practice agreement authorities. 995 medical reserve corps exist nationwide, and there are 50 DMATs nationwide as well. So I think that there's potentially a lot that we could learn from the Rhode Island efforts. In closing, I'd like to just quote our Department of Health Director, Dr. Fine, who leaves us oftentimes saying that we have a lot of deaths to prevent. Thank you.
Thank you, Tracy. Finally, we'll hear from Dr. Sharp Stein.
Great, no problem. Thanks, good afternoon. Thank you for having me. Thanks to the Acting Director Botticelli for bringing everybody together. I have to tell you, when I used to work on a congressional committee staff, I was there for the steroid hearing on baseball, and all the baseball players were on one panel and all the experts were on another panel, and I went up to Dr. Volkow, who was testifying on the other panel, and I said, I know a lot of people's heroes were on the first panel, but my hero is on your panel. So let me jump in. Governor O'Malley in Maryland has 16 goals for the state across everything: economic development, education. One of them is to reduce overdose deaths by 20%. So we have a strong mandate across all of state government to address the overdose crisis in Maryland, and I'll just review some of the things that we are working on. So I'm going to talk about data initiatives, the prevention plans that we have across the state, and some public health interventions. So in Maryland, every death from an unexplained cause goes to one building where the Office of the Chief Medical Examiner does the autopsy. And they do it with a standard protocol. And so we get very, very good data from that about what's going on with overdose. So we have data that goes back. We are able to put out a report. We're going to have the 2013 report imminently. And it'll be up on our website. And these reports can break down by substance, by geography, by age, by gender. And we did see in 2012 exactly what Dr. Green was talking about in Rhode Island: a huge increase in heroin, a decline in prescription opioids. We've been seeing heroin really rising in Maryland since that point. It is almost everywhere. We have, and across the state, we have more overdose deaths than homicides, and it is clearly and yet for homicides, there's an unbelievable focus on every single homicide and what can be done, and overdose deaths weren't even counted really until a few years ago. So we're really thinking, and the governor's really thinking, let's focus like a laser beam on overdose like we focus on homicide. So in terms of data initiatives, in addition to having the data from the medical examiner, we have a health department database of all the overdose deaths. We are able to release reports 3 months after the death at each quarter with valid data from the Office of the Medical Examiner. We are in the process of matching our overdose death data with corrections to figure out the links around discharge and whether people are going back to the same amount they used before and overdosing. We are working with our EMS system and our statewide health information exchange to be able to map both near misses and where overdoses are happening in the state down to the block, basically. In addition to our data initiative, we, since last year, have a statewide opiate overdose plan, and we actually ask every county to have an overdose plan. We've had meetings with every one of Maryland's 24 counties represented. We have these plans. The bedrock, one of the bedrocks is treatment. Maryland invests heavily in treatment. We have expanded treatment tremendously with state funding, about $100 million for Maryland, as well as through the Affordable Care Act and the coverage expansion. We're seeing in Baltimore, where I used to be health commissioner, and people talked about the idea of treatment on demand as just like this crazy thing that would never happen. It's basically there for outpatient treatment in most parts of the city. So we're seeing a big increase. In addition, there are a lot of local initiatives going on, education of providers in different ways across the state, and you can see all the local plans as well online. We do have a overdose response program, which just got set up under a law that allows for non-medical distribution. We actually looked a lot at Massachusetts and New York in their work. We have every single county locally developing the developing a program. We supply the training and approve the training, but these are all run locally. And every county is interested. We have already trained 700 people in the last couple of months, and we're going to aim, we're probably going to have a couple thousand people trained by the end of the calendar year, and they get naloxone. So with some of the state funding, we're able to distribute naloxone. We just had a training of police officers in Anne Arundel County, and one of the officers went right back to work and immediately reversed an overdose. There was some news coverage of that. So we're seeing, we're definitely exploring the naloxone potential. Another thing that we have started as of the last year, we're calling local overdose fatality review teams, and it is similar to the approach that we've taken for child fatality review or domestic violence fatality review, where we get everyone, law enforcement, health, all around the table, and they actually crack open the medical examiner's file and try to figure out in their community what happened, where was it, what can we learn. And we've just been doing this for about 6 months, and already it's very, very interesting. On my way down here, I was reading some of the things that have happened. Just because of getting the right people around the table, people are saying, we want to know who is, how can we get people like this treatment, that maybe somebody was unknown to the treatment system, but totally known to law enforcement. They're like, God, it would have been great if we'd gotten that person treatment. Well, they're now going to be putting together cards of where people can get treatment and getting that through the treatment system, through the law enforcement system, but we also are able to find out if anybody, any of the individuals were in drug treatment at the time they overdosed, and we're going to follow up with every single treatment program and review what happened there and try to make sure that the treatment programs are following good clinical practices to avoid that problem. We're pretty soon going to launch a statewide education campaign that will accompany the real scale up in training for recognizing overdose. Part of this campaign is going to be aimed at family members. Family members have been extremely important in Maryland, getting this on the books, getting the law about naloxone passed, and we're going to do a lot of outreach. We're partnering with our 211 program, which is a 24/7 helpline, so that family members who are worried can call in addition to the individuals getting treatment and assistance. There is a lot of coordination among state agencies, and that sounds like a pretty general statement, but if you knew my governor, Martin O'Malley, you would know that he is incredibly aggressive when he's got something in his sights to get the agencies to work together. And so we are having regular meetings with the governor, corrections, state police. We're going to be looking at all the different issues in terms of access to treatment within the correction system, the use of Narcan by police officers, the ways we can share data back and forth, and it is very exciting to see what it really means for an issue like this to be really at the top of a state's agenda. Just one other thing to mention. We realized one day that we in the health department had the authority to take away a doctor's ability to prescribe controlled substances. It's separate from the medical board. And we use that to look for red flags of prescribing. We look at the top prescribers for Medicaid. We look at wherever there's been anytime there's an overdose death and we can track it to a physician, we write them a letter letting them know. And if they have more than one, they get run through this system where we're looking to see if there are any other red flags. And ultimately, we could refer to the Board of Physicians, or we could take somebody's license to prescribe controlled substances away. We don't do that reflexively, but there's an organized way with the boards, our pharmacy units, everybody looking for data to see if we can identify concerns with prescribing. And we do focus quite a lot on clinical education. We have written every doctor, physician assistant, nurse practitioner in Maryland about good pain practices, about Zohydro and appropriate use of Zohydro, and about just most recently in the last week, we did an update on benzodiazepines because of the concern that we've seen in the overdose data on the use of benzodiazepines. We are also, by the way, seeing the fentanyl problem that Dr. Green mentioned. So I think that's pretty much it. So it is, you know, I think that I've learned a lot today. I think the states can learn a lot from each other, and I think it really signals a tremendous commitment by the federal government to have this kind of event, and we look forward to working with you all. Thank you.
Thank you, Josh. We have time for a few questions. If I see many hands going up, we'll do ping pong back and forth. Okay, sir?
From Trust for America's Health. Dr. Coonens, I'm a 30-year expat New Yorker. When I saw the stats, I mean, the Staten Island really jumped out there. I was interested in the disparities and didn't have time to address if you have any insight on why you know that larger difference.
So it certainly was shocking to us, and if you read the Staten Island Advance, the local newspaper, stories are every week filled with premature losses. We don't have a firm answer to that question. Demographically, Staten Island looks like other parts of the states. It's whiter, it's working class and middle class. It also, we believe, has a close-knit medical community that seems to prescribe in patterns that depart from prescribing patterns in other parts of the city. Our prescribing data shows that Staten Island prescribers prescribe at higher doses for longer days supply and at a higher rate per capita. So we believe the combination of those factors, though we don't really know. The other thing we note in Staten Island from qualitative work that we've done is that there are transitions, as we've been talking about today, transitional use to heroin is occurring for young folks who maybe started recreationally or started because of medical reasons. They are transitioning also to injection use, which we are very concerned about.
Take a question from this side.
Hi, Paul Jarris, the Association of State and Territorial Health Officials. Josh, in your data, 2011, you showed the heroin going up at the same time there's an inflection in the prescription drug overdose. And we hear people, you know, anecdotally say this is because we're reducing supply but not dealing with demand. But have you looked more closely at that to show any either causality or strong relationship between the efforts to reduce prescription drug and the increases in heroin?
So I think that our assessment is, without question, there's causality between getting into trouble with prescription drugs and moving on to illicit substances. And whether it's the, I don't know if I can go far to say it's the efforts to control prescription drug abuse which have gotten the problem worse. I think that there's maybe more of a natural progression. That people start, it just becomes very expensive, and if you're addicted to opiates, it's hard to beat heroin. So, you know, for many reasons. So people wind up moving in that direction. And I think what we would probably say is there's a big wave that came through around prescription drugs, and that we're seeing the impact of that wave as some of the people advance on to heroin. And one of the things we've been really trying to do with our prescription drug monitoring program is emphasize treatment. And it's all over all of our, you know, it is critical that people don't just turn down someone that they see for a prescription drug because they could wind up with heroin. So, you know, it's got to be viewed as a major risk for everyone on prescription drugs, I think.
Thank you. The lady in the back had a question on this list.
Hello, my name is Carol McDade, and I'm from Capital Decisions here in Washington, D.C. And thanks to ONDCP for hosting this forum. It's been very helpful. I've been an advocate here in Washington around these issues for the last 20 years. And I think it's fair to say that in at least my time here on these issues, I haven't seen the amount of bipartisan interest, administration interest, and stakeholder interest in actually coming to solutions. Could the panelists talk a little bit about what happened in their state that took interest in meetings and focus and consensus building and actually used the sense of urgency that we've all talked about today is here, and use it to actually create a tipping point to actually enacted initiatives in your state?
Okay, so we can have brief responses from the panelists, because we do want to take more questions.
I'd just say, big impact in the last year, the involvement of parents. They have been, they have had such compelling stories, very effective with the legislature, and we've had a very strong alliance with them, and has allowed for a greater understanding and some legislation passing that absolutely wouldn't have otherwise.
Donald wants to comment?
In Kentucky, I haven't been there that long, but I haven't seen a lot of movement. I mean, we get in the Courier Journal, the paper in Louisville, at least once every other week, there's an article about overdose, about heroin, but there isn't a lot of movement politically. So advocates have to start moving and get with the politicians, down to City Hall with the police department, and to get more movement on a political standpoint.
I was just going to add data, vigilance, exceptional leadership like we saw this morning, and never really letting the stigma get to you, and to keep it being out there.
Okay. Question back on this side of the room?
Philip Kaufman, San Francisco Department of Public Health. Outstanding presentations, outstanding panel. Thank you very much. With regard to the sort of transitions from prescribing opiates to heroin, I think most of the clinicians who have worked with patients on opioids have seen patients when the opioid restrictions have come in transition to heroin, either back to heroin or onto heroin in the setting of the opioid restrictions. And although it's hard, you can't say with the you can't determine cause and effect when you see these associations, but in multiple localities we've seen opioid prescribing restrictions go into place, and then heroin use and heroin overdose deaths go up. So I think we have to consider that as a real phenomenon, and to me this raises what the ethics are, and I wonder if the panelists could comment on the ethics of opioid prescribing restrictions in the absence of wide availability of naloxone, improved availability of medication-assisted treatment, and something that hasn't been discussed, which is improved availability and payer coverage of non-medication based pain management strategies for those with chronic pain.
Would one of the panelists like to take that? Are you shaking your head yes, Hillary? Sure. Go ahead.
That was a hard question, Philip. Just one point of clarification in New York, two specific points about New York City and New York State. New York City saw increases in heroin use before guidelines, before there was really local attention in New York City, heroin started increasing. I was in clinical practice in 2010, and that's when we started seeing heroin increases. So just to bracket that. I think there is, the other thing I'll just say about New York State is that we, as of August 2013, have a required lookup to prescribe. We're one of, I think one, or someone will know this better than me, states to require physicians before prescribing controlled substances to look up in the prescription monitoring program what other prescriptions their patients are getting. And so we don't know, right? This is the first year out. We're not even 1 year out. What the impact that will be. And I concur wholeheartedly that without the handoff to treatment, the phenomenon of potentially patients getting quote unquote fired would be a tragedy, really a tragedy.
Josh?
Yeah,
Sure.
Couple things. Our increase in heroin predated our prescription drug monitoring program in Maryland. That's why I say it's a little bit complicated. But to the point about treatment, we had a situation where when I was mentioning we can pull somebody's license to prescribe controlled substances. We did that once, and we had a lot of patients in trouble. And we had to scramble. Every time we've done it since, we have a planning meeting with the local health department. We have a contract with the local university that can supply treatment resources. We have a whole plan for patients. We do follow-up. So one of the things that we've learned is that that one doctor can be associated with a lot of patients, and you have to be very careful because we did not want to see people turning to heroin if they couldn't get prescription drugs.
So we're back on this side of the room.
My name is John Edie. I'm the director of the Prescription Drug Monitoring Program Center of Excellence at Brandeis University. And if I may, I'd like to just make a quick suggestion. We had the honor on Tuesday of hosting the 5 New England governors at Brandeis University at the Center of Excellence. And we had a wonderful and lively discussion, as you heard from Governor Shumlin. One of the things we brought into that discussion was a suggestion, which I make to you as well, and that is that we start using PDMP data as an early warning device for looking for where heroin is likely to be the most active in the future. Well, for example, in Ohio, they found that heroin uptake was in the traditional heroin zones in the inner cities among minority communities, but it has quickly moved beyond that into the suburbs and into the rural areas, even the most rural areas of the state. Because of the work that Chris Jones and others have done that showed that 4 out of 5 people who are abusing heroin have started with prescription drugs. The prescription drug monitoring program, if you look at the concentration of doctor shopping, you look at the concentration of prescribers who are prescribing in large quantities, Staten Island, for example, it is likely that you're going to see, or at least it is certainly reasonable to look at those communities as places where the heroin dealers are going to try to market their product because they've got a ready uptake among people that are already there. And therefore, a suggestion is we may be able to get some early warning and get ahead a bit. Law enforcement, prevention, treatment, all at the healthcare system, educators, everybody who needs to know that they've got a heroin problem coming.
Thank you for that comment. I'm not, we have our mic people. I see 3 more hands up. Why don't we try to take 1 or more of them? We do have to exit the stage at 12:15. Isn't that correct, Mr. Botticelli? Yeah. So brief and to the point.
Sure. My name is Andrew Chladni. I'm from Phoenix House and Physicians for Responsible Opioid Prescribing. Just a comment, the transition to heroin use from opioid painkillers has been happening from the very beginning of the epidemic, and rather than efforts to restrict prescribing, what is beginning to happen is the medical community is beginning to realize that opioids are not safe and effective for most people with chronic pain, and that we really, in many ways, created this mess. My question is, we heard from Dr. Coonens about an effort in New York City to communicate to the medical community this very point, that opioids are not safe and effective and that we can get patients addicted. I'm wondering about whether or not there have been similar efforts in Maryland or Rhode Island to communicate to doctors, well-meaning doctors, not necessarily closing down pill mills, which of course we have to do, but to communicate to doctors who really are trying to help their patients that this is not safe and effective for low back pain.
Okay, quick answers.
The Board of Physicians has contact information for every licensed physician. We have done multiple communications to physicians through that on best practices for pain prescribing, the issues with benzodiazepines, and specifically around Zohydro.
And for Rhode Island, the Department of Health's website is full of resources for prescribers. And in fact, every page of the Department of Health has a link that says, are you a doctor? Do you need a referral for addiction treatment for your patient? Click here, and that will link you to any resource.
And I also, as an HHS representative, want to put a plug in for the Centers for Disease Control and Prevention, which recently has been highlighting this as a national issue, which I think also the states then can use to move forward. Let's just hear from Daniel, and then I'm going to turn the podium back over to Mr. Botticelli.
Thanks, Ryan, and thanks to everyone. Daniel Raymond from the Harm Reduction Coalition. It's been remarkable and gratifying to hear the consensus around the importance of naloxone in broader overdose prevention strategies, which I don't think that we would have heard if we were convening this meeting 3 years ago. So that's a very dramatic uptake of this intervention. Can we translate the energy and the urgency to other areas like neonatal abstinence syndrome, hepatitis C prevention, where substitution treatment for pregnant and parenting women is still controversial, syringe access for people who inject drugs is still controversial, in a way that I think some of us experienced the controversy around naloxone several years ago that has now been settled and resolved. What would it take to translate this energy and urgency to these other critical strategies?
Okay, not an easy question, but I don't know if anyone might want to put forward an easy answer.
I feel like we have many, many tools that we've developed, real-time prescription monitoring programs, states that know how they can use their data. They can incorporate and actualize naloxone distribution in their communities very quickly, like in Rhode Island. Each of these, you can add onto it neonatal abstinence syndrome and addressing safer prescribing in a pregnancy and referrals for treatment appropriate mechanisms like that on top of prescription monitoring programs. So our academic detailing perhaps could go to the OBGYNs to encourage use of prescription monitoring programs, for instance.
Other thoughts that anyone wants to share? Josh?
I just say we're very involved on some of those issues. I think that the challenge is each of these issues has its own set of pre-existing beliefs you're kind of butting up against. And so we've been working very hard with some great leaders all across the state on the myths associated with methadone and buprenorphine treatment, which is highly effective and getting it, and we're making some progress, but it's actually easier to get people to understand Narcan. It's just an easier thing to understand than when you've got maybe 10 years of misconceptions that you're working with.
Hillary, did you want to say anything?
I urge us all to think about ways to get urgency to these other issues, as Dan said, because it's very powerful.
Donald, any brief comments on that?
I think that where I'm at, and we have to continue to look at naloxone and hepatitis C and bring the other ones into play, because we don't have that. We're in Kentucky. We don't have, we just don't have it.
Yeah. So, and I'll add my 2 cents, is that we need more stakeholders who see the problem from a medical and public health perspective. Because I think having the same people talk about why it's important probably won't move us on controversial issues. But let me end by thanking the panelists for an outstanding job. Let's give them a round of applause. And welcoming Mr. Botticelli back to the stage.
So, I know that a couple things I'll say in closing. One is, obviously we probably could have been here for a week doing presentations of the work that many people are doing. So, this was really meant, and I think what was helpful for me, and I hope you found for you, is, how does all of this work kind of bubble up emerging themes to kind of what are successful efforts, but where do we need to go? I want to talk about a couple things, because one, this issue of transition keeps coming up over and over again, right? So let me just, for kind of clarity's sake, because we didn't really present that data, to show what the data say. Right? So what we know in terms of people who have initiated heroin use within the past year, 4/5 of them have started on a prescription pain medication. But I would be remiss if I didn't say that the vast majority of people who are addicted start very young on alcohol, tobacco, and marijuana. So it's not about that first use, and I'm sure all of the clinicians in this room will attest to the fact that prescription pain medication was not the first drug of abuse. So we have to talk about that in context. The other thing we know is this is information from the National Survey on Drug Use and Health. For those folks who are misusing a prescription pain medication, only about 4% appear to be transitioning to heroin, right? So this is 2012 data. So I think it's important that we not take our eye off the ball on prescription drugs. So there was a very interesting article in Governing Magazine that said heroin's not the issue, doctors are. And right, so how do we deal with these prescribing issues? Because, we can't, while we need to think about heroin-specific strategies, it's really the misuse of prescription pain medication that are driving the increase in heroin use. So we have to think about multidimensional strategies here and not take our ball or think that diminishing the supply of prescription pain medication is responsible for, and entirely responsible for that transition. The other thing, Daniel Raymond, I think your question was probably more appropriately directed to ONDCP as it relates to things about how do we harness the energy that we have here in the room about some of these systemic strategies, bring the same momentum around hepatitis C and neonatal abstinence syndrome. And I don't think we could agree with you more in terms of those pieces. And so at the federal level, ONDCP has been coordinating with Ron's office in terms of the Viral Hepatitis Action Plan, the Office of National AIDS Policy, to look at how do we make sure that we're syncing federal strategies and we're thinking systemically on how do we deal with this issue. And I also want to point out some of the people that we have in this room is indication of how we need both at the federal level, how do we work with state and local partners. So we have Julie Schofield and Chris Taylor here, Paul Jarris from ASTO. So, you know, I think, and the precise point of this meeting was to say, where are we now? What are the emerging trends? How do we have to deal with it? So we've also been working around a strategy, I won't say a strategy, I get in trouble because that's like some produced thing, but how do we continue? I know, there's certain rules of the road I'm learning. But how do we kind of augment our current work to really address neonatal abstinence syndrome? And you all have a role to play. I think all of us have been concerned about the increasing criminalization of pregnant women, who particularly as it relates to this opioid epidemic. So again, I think we have to think about a systemic response. Just, I'll try to kind of, in my meager way, to try to sum up, I think, what some of the things we heard. And so clearly, I think this theme about how do we collaborate, how do we bring everybody together that has some level of understanding to bring to bear to this, but also a part in the solution. And clearly, data sharing was one of the areas that we heard a lot of focus on. So how can we each have a piece of the data here, both public health and public safety, and I think Hillary's work in New York in terms of targeting that and really looking at public health and public safety data is really important, and John talked about this as well in terms of PDMP piece. Many of us who've been doing public health work for a long time often get frustrated at the delay in our data. And again, many of our public health partners and other data sets have more real-time data that can really help us to think about who's being affected now, how do we target our data. I think Josh's work around establishing mortality review committees around this is really interesting in terms of looking at this on a case-by-case basis. We've been doing this in public health-related efforts for a long time, and I think it does reveal good work. I would also encourage folks, if you haven't established relationships with your individual high-intensity drug trafficking areas, so these are ONDCP-funded groups that often, to your point, John, about how do we identify emerging markets here? Well, part of what we've been trying to encourage is involving our high-intensity drug trafficking areas, because these are people, they're not across the country, but in the high-incidence area, and who are really looking at drug trafficking trends and have a really good handle on the market. So they can be really good opportunities to do that. We heard some, I think, really innovative work. So I think, Tracy, you were talking about disaster management, which I think is a really interesting, those are not folks who we historically have engaged on this issue. And I think it's really important to do that. Let me also talk about transition. One of the things, we actually have a federal interagency group working on, and our partners at NIDA are going to pull together a group of folks to really say, what do we know about transition? What can we do about it? So we really, I do think, need not only better information, but better research about this issue. I want to talk, because I think it would be a missed opportunity if I didn't talk a little bit about language. And just hearing the different language that people use in the room today. And I also want to give an indication, a shout out to Dr. Sharp Stein, who wrote a really excellent piece about the stigma and the language that we use around opioid treatment. So it's probably the only disease where we classify the results of tests as dirty and clean. And so if there isn't a moral underpinning to that kind of language, and that comes from the field itself. So, I also think, if you haven't seen the work of Dr. John Kelly, who's actually been to the White House before, he heads the Recovery Research Institute at Mass General Hospital in Harvard, did some really interesting work, even with trained mental health clinicians and substance use clinicians. Presented them the same scenario. One scenario said people with substance use disorders, and in another scenario used substance abusers, and found, even among trained professionals, a different willingness to help someone who was called a substance abuser versus a person with a substance use disorder. So, we've been talking a lot about stigma, and so there's some really low-hanging fruit here that we have some responsibility to change. So I think we need to kind of reframe some of our language about what we do and what we call people and what we call results. So, my friend Carol McDade usually hits the nail on the head with the appropriate question, which is really, how do we take all the action, all the energy, all the expertise in this room and change it and turn that into actionable work? That's really the crux of the issue. You know, and I do think it takes, and I think what we've seen today is kind of takes at least three fundamental ingredients. One is leadership. One is the importance of how do we harness leadership at the state, local, federal, state, and local level. You know, and so I hope kind of by this meeting today, you understand that not only ONDCP, but many of our federal partners, this is our top priority as it relates to drug use issues, and we have to continue to do that. I also want to thank a lot of the congressional staff who are here today. We've had multiple conversations and multiple hearings. I hope about how do we move this. I hope some of the information today presents a pathway forward to further congressional action on this issue. We really have been heartened, and I would agree, Carol, that about the bipartisan interest and focus on this. So I do think we have that. The other piece that I continually are profoundly moved by are the role of advocates and the role of consumers in this. And I will tell you, during my time in Massachusetts, you know, I used to say that I unfairly got a lot of credit for a lot of things, because it was really parents and advocates that changed the conversation. And the reason that Lieutenant Glenn and the Quincy Police Department carries naloxone is not because of the state. It's because parents whose kids were affected by this and overdosed said to him and his chief and his mayor that you need to have naloxone. So we do need to kind of simultaneously think about how do we promote, how do we coordinate this active, angry, and motivated group of parents and other affected consumers. And I do think that we each have a collective responsibility on that. I will end with well, two things. One, I just want to thank everybody today, the panelists particularly, for all of their work, all of you who are traveling here today. But really end with, I think, what Dr. Volkov talked about, is that we have the knowledge and we have the tools. We have the innovators, but we also need to kind of redouble our efforts around the will to do this. So you have our pledge that we will continue to do this work. We will always do this in partnership with you. We continue to want to hear about the innovative work that you're doing and how our office and other federal partners can help sustain that. We also know kind of resources are a challenge, and you know, to the extent, let me just also say that I think what's helpful is if you look at the federal drug control budget in total, that has actually gone up. And it's gone up in light of federal resources going down. And the biggest increase has been on the prevention, treatment, and recovery side. So, you know, again, not a lot of money out there, but we're trying as best we can to make sure that we have the resources to do that, and we'll continue to be your champion. Thank you all for being here today. Thank you all for the work that you do. It's really, the National Drug Control Strategy is really comprised of all of the good, innovative work that you're doing on a daily basis. It is one of the greatest pleasures I have is to talk with the people who do this work on a day in and day out basis. That you're some of the most passionate, commitment, and humane people that I've ever met. And so Tracy talked about the fact that we've done this in other areas, and we can do it now, and we will do it now. So thank you very much.